burns, the first thing I'm going to talk about is smoke inhalation. So you can recognize it early because these patients are going to need to be prophylactically intubated within 2 hours of reaching the hospital. So anyways, there's 3 different types of smoke inhalation injuries. There's metabolic asphyxiation, there's upper inhalation areas, and then lower respiratory inhalation area injuries. And I kind of just combine lower, upper, and lower together so you don't have to memorize different signs and symptoms. But with metabolic asphyxiation, essentially this is carbon monoxide poisoning. And this happens anytime somebody has a burn injury that occurred inside. So inside a building or inside a house, okay? So they develop carbon monoxide poisoning. Carbon monoxide poisoning is dangerous because it impairs O2 consumption to the tissues. And what carbon monoxide does is it takes over for oxygen on the red blood cells. But if you get an ABG, the PaO2 and the O2 sat are going to be normal. They're going to look really good. But carbon monoxide is like mimicking the oxygen. Okay, so what you're going to need to get is a oxyhemoglobin level. And if it's greater than 10%, that suggests carbon monoxide poisoning. Carbon monoxide poisoning, the signs and symptoms are due to the fact that carbon monoxide is a vasodilator. So you'll see those cherry red lips. They'll have a headache. They'll be dizzy, nausea and vomiting. They'll have dyspnea and confusion. They can get downright belligerent. That's like one of the key features of carbon monoxide poisoning. So how you would treat this is you would put them on 100% O2 to try to displace that carbon monoxide. Then with upper and lower inhalation injuries, you need to be able to recognize them. So some of the signs and symptoms you'll see is like soot inside the mouth, singed nasal hairs, singed facial hairs, a brassy cough, hoarseness. A brassy cough, students always ask, is kind of like a croupy cough. And copious secretions. They may have wheezing. Now, if they have wheezing and then you come back and listen to their lungs again in an hour and they don't have wheezing, that's not a good sign, okay? That means the airway there's not air moving through the airways. So what happens in burn injuries, and this is why it's so important when they come in to get 2 large bore IVs in, what happens is, if you can see this picture right here, this gentleman is very edematous, okay, because of the trauma, and I'll explain it in depth a little bit later. Because of the trauma, they're going to end up getting extremely edematous like 10 to 12 hours later. And the epiglottis can swell and the airways can swell. And plus, you're giving a lot of fluids that essentially really get into the third space. Okay, so that's why we need to prophylactically intubate people that have inhalation injuries. Now, on your exams, you're going to need to identify different burn depths. Like you'll get a question like somebody has a partial thickness, superficial, what do you expect to see? But you'll also get a situation where they tell you what's there and then you have to determine what it is. Now, when we talk about burns, there's 3 ways we classify them. One is burn depth. The other is total body surface area. The other one is by the severity, and you need to know all 3. Okay, so let's talk about burn depth first. With burn depth, the characteristics you're looking at are color, edema, pain, blisters, eschar, healing time, and are there grafts required? So the first type of burn is a superficial burn, and this is going to be red to pink, and it blanches. Edema will be mild. Pain, yes, this is a sunburn. It can hurt. No blisters, no eschar. This is the epidural layer, so this is going to turn over really quick. They're going to heal really quick from that, 3 to 6 days. Now, with partial thickness, superficial, this is in the dermal layer. So this is the upper 1/3 of the dermis. This is going to be pink to red. It does blanch. Don't confuse this with superficial. It's partial thickness superficial. It's mild to moderate edema. They will have blisters, small blisters are going to be kept intact, but then the nurse would debride the larger blisters to promote healing. They usually do not have eschar, and they heal within 2 weeks, and no grafting usually. Um, with deep partial thickness, these burns are going to be red to white, and this is a new color that shows up. The edema is going to be moderate. They're going to have a slow capillary refill. Okay, they will not. They will have edema. They will not have. Um, they could have a blister, but it's really rare at this level for them to have a blister. They will not have. They will have eschar, but it's not leather type eschar. It's soft and dry. This is going to take 2 to 6 weeks to heal, and it can. The pain may be a lot if the healing is prolonged. Okay. Now with full thickness, this is, I call the rainbow. All these colors come out: black, brown, waxy, yellow, white, charred. No blanching. Um, they will have severe edema here. That's because this is in the hypodermic layer, and that's where your blood vessels are. They don't have pain within the burn injury, like around the edges, they can have pain. All right, the eschar is going to be hard and inelastic, and it's going to be like leather. So I remember L for full thickness, okay? That's how I remember that, because there's L's in both those words. It's going to take weeks to months to heal, and they will need grafting. And in the dermal, in the hypodermic layer, okay, this is where your vitamin D is activated. There's going to have no activation of vitamin D, so they may need supplements. But the other thing you worry about, especially because of the leather eschar, is that they could get compartment syndrome. So remember, the hallmark of compartment syndrome is that they have pain despite being given opioids, and you've done all the comfort measures. That's your tip off. And you're looking at the pulse amplitude. Normal pulse should be +2. You're looking at, remember, your 6Ps, okay? So make sure you're checking that you learned in Med-Surg 1. With deep full thickness, okay, this color is going to be black. The tendons and bones are going to be exposed. No edema, no pain. Well, pain around the edges. They will have leather eschar. It's going to take weeks and months to heal. And they will need extensive grafting. Okay, so remember the 5Ps or 6Ps. Pain, you're checking the pulse and its pulse amplitude. Parlor, you're checking if it's pale. Perianesthesias, paralysis, and also poikilothermia, and that just means the coolness. Okay, so you don't want like a cool limb. You want it nice and warm. All right, so that's burn depth. And now I'm going to talk about total body surface area. Usually students already know this. This is the rule of nines. The rule of nines, each body area is assigned a denomination of 9. And you'll be giving examples, like it'll say like the right arm was burned. If it says the right arm, that's a 9. If it says back or front, that's 4.5. Okay, so basically just write it out on your exam on a piece of paper, because it's easy to skip over body parts when they're written in a sentence. Okay, so just write them out, assign them a number, and add it up, and then get your rule of nines. For the burn severity, okay, there's 3 different categories in the burn severity. There's minor, moderate, and major. Okay, and you're going to need to know where your patient falls. Okay, so for minor, this is partial thickness burns, less than 10% total body surface area, and full thickness burns, less than 2%. This does not meet the criteria for a burn center, so they can go to the ED, or they can have care even at the scene, and then be taken to the ED. For moderate, this is partial thickness burns 15 to 25%, or full thickness burns 2 to 10%. This also does not meet the criteria for, or if they don't meet the criteria for major burns. Anybody greater than 10% total body surface area is going to need tetanus shot. And then they're treated at the scene and transferred to a burn center. I mean, they don't have to, but that's probably best practice. The major burn category, now they are definitely going to have to go to a burn center. This is partial thickness burns greater than 25% or full thickness burns greater than 10%. For partial and full thickness burns greater than 10% of total body surface area in clients under the age of 10 and over the age of 50. Okay, so if they're under the age of 10 or over the age of 50 and they have partial and full thickness burns greater than 10%, they need to go to a burn center. Also, any burns involving eyes, ears, face, feet, and perineum, because these are the areas we really need to function in life. Electrical injuries also are going to go to a burn center, and inhalation injuries. Anybody older than 60 needs to go to a burn center, especially if they have a history of cardiac disease, pulmonary, or other chronic illnesses. Burns complicated with other injuries also can go to a burn center. So you are going to need to know the Parkland formula, okay? And I'm going to teach that to you. I want to say something. In the first phase of burns, the emergent phase, or the resuscitation phase, whichever you want to call it, it's the same phase, okay? You want to get 2 large bores IVs in as soon as possible because the patient is going to be swelling over the next couple of hours. They'll have massive anosarca, massive edema. Okay, so you need those IVs in because they're going to need a lot of IV fluid. And as the IV fluid, we use lactated ringers. So the formula is 4 mLs times the kilograms times the percent of total body surface area burnt, okay? So if a person weighs 50 kilograms and they had 50% of their total body surface area, you would multiply 4 times 50 times 50, okay? Some students try to do a percent of 50. No, just 4 times 50 times 50. Once you get that figure, that's your fluid volume the patient needs in the first 24 hours. Then you're going to divide it by 2. When you get that, that's the amount of fluid the patient needs to get in the first 8 hours. And the time starts from the time of burn, not arrival to the hospital. Okay? We did an example in class, so make sure you look over that again. The goal of the urine output is 0.5 milliliters per kilogram per hour. We never give furosemide to stimulate urine production. You give the fluids as prescribed, and if your patient goes into like pulmonary edema, you titrate down. Okay, electrical burns are the only type of burn that can get mannitol, and the reason for that, that's to prevent an AKI, because remember with electrical burns, they're the ones that are called like the great masquerader, because the burn wound looks so small, but yet it creates massive trauma inside the body. And so, they can get rhabdomyolysis. So that's what you're trying to prevent, an intrarenal AKI. All right. Burn health promotion and maintenance. Basically, it's using common sense, like, for example, checking bath water before you get in. And especially you have to teach that to diabetics and people with peripheral vascular disease. You never want the water greater than 120 degrees Fahrenheit. You should wear sunscreen greater than 30 SPF. And then no smoking in a house with oxygen. You have to go outside, not in another room. No smoking in bed. No smoking, drinking, and doing drugs in bed. Make sure your electrical outlets aren't overstressed and you don't have a lot of wires. I mean, I know that's a problem now because everybody has to plug in their phones and their computers, etc. And then make sure you have carbon monoxide detectors in your home. with pre-hospital care, first thing you got to do is get whoever, if you're in a burning house, get people out of the burning house and don't run into a burning house. Nothing is worth it. So you're going to do your primary survey. Remember cervical and airway, breathing, circulation, disposition, and exposure. It's best if if you're there, if the you can start treating the burn within a minute. The first thing you're going to do is start irrigating with cool tap water. Okay, don't put butter or oils on patient's skin. And I know that's a wives' tale, but you just can't do it. And you're going to do that for about 10 minutes, and you never want to have somebody immerse in like a cold bath or anything. Okay, you're just going to irrigate. And then if they have chemical burns, the irrigation does go for a very long time. But you do have to get your patients warm too, because the burn, your skin protects you and keeps you warm. All right, now in the emergent phase of burns, okay, also called the resuscitation phase, this is what happens, okay? So there is major capillary damage. Like the capillaries get very leaky. And when the capillaries get leaky, albumin goes out of the capillary. Well, water follows and sodium follows water, okay? So to recap, a burn injury is going to cause major capillary leaks, okay? With the capillary leaks, the albumin goes out of the cell. The water or the fluid follows, and so does the sodium. Okay, so that's what happens in a burn. And this is going to happen for about 24 hours. So in the early phase, okay, so again, albumin is going to go out of the capillary, sodium is going to go out of the capillary, water is going to go out of the capillary. Potassium is going to come out of the cell. Okay, so this is what you have to know these labs. You're going to expect a high hematocrit due to hemodilution, because all the fluid is going to start leaking out of the capillaries into the interstitium. Low albumin, low sodium, high potassium. Also expect a high specific gravity, high BUN, and high glucose. Okay, and the glucose is because of the stress response. Okay, so with the burn injury, again, this vascular permeability, so that leaky capillary, it decreases the intravascular volume, which increases the crit, which increases the viscosity of blood, which is going to increase the peripheral resistance. There's going to be massive edema, decreased blood volume, increased peripheral distance. So basically, hypovolemic shock is burn shock. Okay. So that's what people die of early in burns. They die of hypovolemic shock. All right. Now, your patient is going to be at risk for shock. Hypovolemic shock usually kills people in this phase. Deficient fluid volume, decreased oxygenation. Now, since they have leaky capillaries, okay, you need to protect them from getting acute respiratory distress syndrome, which could be due to either hypovolemia, trauma, or when they get in the acute phase, sepsis, okay? Because usually infection and sepsis occurs in the acute phase, okay? So look for your low oxygen, try to prevent hypovolemic shock, try to prevent sepsis too. Okay, so those are kind of the problems you have. I'm not saying pain is not a priority, but you have to make sure the patient has, the ABCs before that. Oh, here we go. Okay, so your priorities include the A, B, C, D, E. So that is, make sure you've got an airway. If the patient was involved in an electrical burn or trauma along with the burn, make sure they have their Philly collar on if they need, or the Aspen collar if they need it. Make sure you have 2 large bore IVs. Lactated ringers is the IV fluid we use. You can give morphine for pain IV, and your goal is going to be a urine output of 0.5 milliliters per kilogram per hour. Now, your interventions during this phase, okay? include the airway. So you're going to worry about edema of the larynx 8 to 12 hours after the burn injury because all the fluid is leaking out of the capillaries into the tissue. That's why they're prophylactically intubated. Monitor for ARDS. Remember, ARDS is a type of non-cardiogenic pulmonary edema. So we want to prevent that. It's a type of hypoxemic respiratory failure. So the PaO2 will be less than 60 despite 100% O2. Or if the patient has inhalation injuries, both of those types of patients will be intubated. With ARDS, you want to make sure to kind of prevent it. Treat hypovolemia aggressively so that's why they get a lot of fluids. Early enteral feeding, so the protein really helps prevent ARDS. The patient may be placed prone and they're probably going to need PEEP. Okay. With breathing, make sure the patient is moving air by using your stethoscope on their chest to make sure. Now they're probably going to be intubated. Okay. If they had a full thickness circumferential around their chest injury, they may need this escharotomy. How you would know is that your high alarms on the ventilator would be going off because this leather it doesn't allow the chest to move. That's why they need this escharotomy. Okay, they're going to need to be paralyzed and sedated, definitely. And then with circulation, you want to prevent hypovolemic shock. That's going to help prevent ARDS as well. Okay, so they need their lactated ringers. You're not going to give furosemide. You want to monitor the CVP. Electrical burns, the first thing you're going to do, one of the first things is get them on a monitor, right? You're going to monitor for VFib. You don't want that to happen. They may need mannitol to prevent them from getting a renal AKI. Okay, and then with a high potassium in the early phase, okay, look for your high peak T waves, your widened QRS, your prolonged PR interval. So that's first degree block. So we'll monitor for that. Monitor the urine output. Monitor for signs of shock. Now, a Curling's ulcer is an ulcer that occurs after trauma, so a burn injury. So patient's gonna need to be on some type of prophylaxis, and tube feedings help that, but also probably like a PPI or an H2 blocker to prevent them from getting ulcers, especially if they're like intubated as well. That's a double whammy. Check the blood sugars. They're probably going to have high blood sugars. Remember, that happens when people are in shock. Paralytic ileus is also a problem. You want to make sure you are feeding patients as soon as possible with enteral feedings. Okay, we always use the gut if it's working. You want to prevent overfeeding, so put residual back in unless it's excessive. So excessive would be like 2 times the normal rate. Like if the rate was 200 and you had 100 residual, you may have to hold it for a little bit. Okay, so check the placement via chest x-ray of the feeding tube and keep your head of bed 30 to 45 at least, and then make sure your tube feeding is at room temperature to prevent cramping. With disability, you're looking for new onset symptoms such as confusion. With exposure, your patient is going to have a high temperature, not high temperature, but like they can have a temperature for a while. And the reason for that is when you have a burn injury, they're in like a hypermetabolic state. And this is important for you to understand because this is why we have to make sure we're feeding them appropriately. You need to keep the room temperature for burn injury patients. Remember, your skin helps insulate you from the cold so that, they're going to have exposure. So you need to make sure the temperature of the room is at 85 degrees. All right, the acute phase of burns, this occurs about 36 hours after, it can be up to 72. The patient starts diuresing. And when they start diuresing, the sodium is going to be low, the potassium is going to be low, and they could have anemia. So this is what happens. The all the fluid that went into the interstitium now comes back into the vascular space, okay? And then you got to watch for pulmonary edema and weight gain in this phase early on, okay? So monitor, and then in the acute phase is when you are going to monitor for infection, because this they usually die from sepsis in this phase. It's the leading cause of death, okay? So this is where they have like physical therapy, occupational therapy, depending on the type of burn that they have. I have this picture here about burn dressings. If you have a digit like hands and feet, you want to always dress them separately. Okay, so you never want to put like a mitten type dressing on somebody. Okay, and you're going to have to, take care of the pain. Anybody that loses 10% of their body weight, you're going to need to modify that diet. They're going to need high protein, high carb diet. Remember, they need good nutrition because they're in a hypermetabolic state. And so you need to make sure they're eating properly and getting what they need. You also want to, if they're on like a ventilator, make sure you're emptying that water out of the corrugated tubing, because Pseudomonas loves water. So that's why we don't let them bring fresh flowers in to the room, because Pseudomonas can grow in water. Okay, so we always want to prevent infection. So there are different modalities they can use for wound care. The open method, usually that's reserved for face and perineum. Remember, the temperature needs to be 85, or patients can undergo the closed method, which is probably what you're used to with dressing. Okay, so that's like the closed method, bulky dressing on them. With mechanical debridement, this could happen during hydrotherapy, and they get put on this table. They're not put in like a whirlpool. We don't do that anymore. They're put on like a shower table, and the nurse will wash down their wounds, and then they will debride them with scissors and these tweezers. So make sure they're medicated now before they go. So with PO medications, you want to give them 1 hour before, and with IV at least 30 minutes before. Okay, so that they're at like the peak level when the patient is getting debrided. There's also enzymatic ointments they can use, such as Santal, which is collagenase, so that penetrates slowly. Silvadene, you're going to watch out for neutropenia. This also penetrates eschar slowly. Mafenide, now this provides bacteriostatic protection. But the thing with mafenide, and how I remember this, is mafenide begins with M and A, and they can get metabolic acidosis from this. That's how I remember. With gentamicin, you have to worry about their ears and their kidneys when you put that in the wound. And the reason they use ointments is because there's a poor blood supply usually to the wound. So this helps prevent infection or treat infection better than IV antibiotics. Okay, biological dressings are another thing, and they can help with the pain as well, because if the burn is exposed, patients feel pain. So covering the burn can help. Surgical management, there's all kinds of grafts they can get. They can like take the patient's own skin and put it through this like mesher, okay, to kind of like spread the skin out, so to speak, and then put it over. See, look at here, put it over the burn wound, and that has like staples in it right there. That looks painful. But they do all kinds of things like that. And then with rehab phase, this is the longest phase. Um, Patients sometimes have to wear these stockings for like 24 hours or compression, and this helps prevent contractures. So that's why they do that. So to recap, lots of different causes of burns. The most common is thermal. The depth we talked about, so you're going to have to be able to recognize that. They're going to come in, you're going to the ED, do the ABCs, do the rule of nines, the Parkland formula we talked about the first half being given in the first 8 hours, and then the next half being given in 16 hours. Make sure you get those two large bore IV lines in. And if they do have carbon monoxide poisoning, you will get carbon oxyhemoglobin levels measured, and they'll need 100% O2. Okay? So that's it for burns.